welcome all to the free GP OSCE orientation course. And my name is Dr. Rizwan Qureshi. As you know that we have been working with quite a lot of MRCGP candidates, getting them partial comparability outcomes to substantial comparability outcomes from the people who are coming from the UK as well. I just wanted to take 5 minutes of your time to highlight the importance of the exam. Now, obviously, all of you who are taking the OSCE exam are already committed to this exam. I don't have to tell you what's going to be the difference about in terms of exams, the preparation. You already know that. What I want to highlight is that what is at the end of the tunnel. Now, since March 2023, since MRCGP International has been sort of recognized towards the PEP pathway, leading eventually to FRCG pathway, we've had a significant amount of interest. And the candidates have been flocking pretty much from every region, Pakistan, Sri Lanka, Bangladesh, and Middle East in particular. Lots of people are coming in from there. And I think it is primarily fueled by the deficiency as per the recent consensus on Department of Aging report, which was issued in last 2023, that there is significant deficiency of general practitioners in the regional, rural, and remote Australia. So what RACGP has done, it has utilized this MRCGP candidates along with all the other rest of the exams from various GP colleges throughout the world to come and work independently under minimal supervision, which we are calling level 3 supervision through PEP pathway. And what it entitles you to do is have your own patient load, see the patient, discuss them with your either on-site supervisor or off-site supervisor if you need to, but we can pretty much have your own patient bulk load from day one. Not only that, it is, primarily right now concentrated towards the region. I won't say that we have gone into rural or remote locations as yet. It is primarily in the regions, and the regional Australia is the region where there are major towns and they've got schools, they've got small hospitals, they've got good road links. Some of them have even got like airports as well, so they are quite well set out. It's not like you are in the middle of wilderness and there's nothing else happening in there. You are in a pretty well supported environment. And you know what I've seen, Dr. Saira, more interestingly recently, is the GPs who are coming in from Middle East and Pakistan, they are coming in groups. So they are
Really?
like, I like my 4 friends, we are all going to be, and they've all been signed by the same GP practice.
That's
So now
wonderful.
we've got these regional towns which will have 20 GPs from the same area in Dubai or Karachi, which is amazing. We've
Yeah,
never seen this kind of migration in which the friends and the families are relocating together, and it's a very favorable trend. Now, in terms of salaries, people often ask, and I just don't want to blow any bubble, but the salaries are good. I know that, look, MRCGP in Pakistan and in other parts of the world, including in Dubai, the salaries are not good. But here, the salaries are standardized. You're getting 60-40 or 65-35 partnership to up to $250,000 gross salaries, which is amazing. And I think if the more regional or the more outward you go, there's savings, because the living expenses are so economical there. The houses are expensive through the roof. You can't get a proper house with 3 bedroom in Sydney for less than $800 to $900 a week. But in the regions, it is possible to have a house or a very well structured unit for half that price. So regions have got this potential of having good salary plus good savings. So it's a good balance. The other thing people often ask me about is, the visa. So you'll all be given visa. Some of the practices which are desperate will sponsor a permanent residency, but there are few and far between these practices. And it's good to come on visa. You come and you work, you assess how you're enjoying the practice. And once after a year or two, if the practice is happy, they can go on and invest in a permanent residency visa. Look, I kid you not, most of the doctors who are coming in through practice experience pathway will be a permanent resident, most likely even without the FRCGP exam. FRA-CGP exam is, however, important. It's important for your professional growth. So I would strongly advocate and advise, do not come here with a thought process that I just want to come here, work as a GP, and I just want to get a permanent residency and passport. This is just the beginning. The good things will only start when you get FRA-CGP, which gives you full Medicare rebates, which means better salary. You'd be potentially able to move out into better regions, into the main cities down the line. So it is an ongoing investment into your future. Don't oversee that crucial and fundamental aspect of this pathway. It's an investment which is going to get more fruitful as the time progresses. So dedicate 12 months, 24 months of your time, pass this exam, get on your training requirements which are mandated by the college in the 6 months or 12 months leading up to the exam, and you'd be done. And once you've got, as I said, FRA-CGP, you are fully what we call vocationally trained GP. That is, you're fully recognized as an Australian GP. There's no difference virtually between you and Australian GP, and that gives you whole heaps of entitlement. Now, there are courses available on MRCGP, and I would like to just say that, look, a good OSCE course. OSCE is one of the things which I sat as well, not for a general practitioner, but for emergency fellowship exam. And OSCE is the thing which is heavily confused in any aspect. People often think that, you can read about certain concepts and you can just regurgitate you have to use to stand out the chance of passing the OSCE. So I think the course that we are trying to provide, it's going to have the best of the both worlds. It's going to have an updated content from the exam point of view, plus the relevant content, which is going to be helpful in the clinic while seeing the actual patients. It's practical. You need that. There is no point in passing the exam and then be in a situation where you are struggling to manage the patients correctly. So it's all built on Australian and the UK protocols, which you would be commonly utilizing to work here in Australia. Our OSCE course, obviously, it's 2 live sessions per week, very doable. And if you miss a session, you can have an access to a portal. So it's no longer Google Drive. Those are the things of past. It's all a portal. It's like, everything is according to your review of the sessions. So if you stop the session at 15 minutes mark, you can resume the session automatically next time you log in from that 15-minute mark. It'll keep track of your progress. It'll keep sending you reminders of your progress that you've done session 1, session 2, session 3, session 4. Session 5 is pending. You will get weekly reminders. So those online portals are very good from that point of view of reminding and everything. So huge potential for MRCGP once you've completed in terms of job, in terms of your professional growth and development. And I think it's one of the rare opportunities, and time never waits for anyone. And I think grab that opportunity, seek it to completion, and I think you'll be in good company. We've had about 14 GPs, Sarah, coming in this month from MRCGP route to Australia through our pathway.
Yeah.
So I think, I'm only going to see that, look, this is the first cohort of GPs coming in. This year we've had many GPs coming in, and people are still registering into PEP pathway. So happy to help you there as well. So all the best. I'll get Sarah to talk about the course and do a primary session, and we'll take it from there. Thank you very much.
Well, thank you very much, Dr. Rizwan. It was very insightful, and I'm sure that it must have cleared the doubts of many people, which they may have in their minds. It was very insightful. Thank you for that. So we are going to begin our session today. Right, let me just... Okay. So I welcome you all to the MRCGP OSCE course, the free live session, of course. Okay, so I'm Dr. Saira Azhar, and I'm family medicine specialist and also a course director for this course. I'm the course director and also managing director at Emergency Focus. And I am by passion a GP educator. for more than 3 years. Right. So welcome to the session for MRCGP course 2024. So this session will be a live practice session. It will commence from November 1st. It will be a 12-week course, Mondays and Wednesdays, the classes. And the topics, I've made sure that they align with RCGP, Royal College of General Practitioners curriculum. And they also include the topic, the difficult modules, which I think most of the GPs have never heard of while they were practicing, like genetic cases, which comes up. Actually, one of my case was on genetics, right? So what is autosomal recessive? How do you explain it to your patient? And cases about medical complexity, where you come across a patient who comes with multiple complaints or multi-system complaints, right? So this course will contain more than 100 role plays covering all modules as per our CGP curriculum. And there will be a mini trial exam at the end of the course, and you'll be issued course participation certificates. And for your professional development, or if you consider to plan for Australia via PEP pathway, it would be sufficient for it is one of the requirements by RACGP via PEP pathway, so it will cover that as well. So it's a one-stop shop to your career in Australia, right? So we are going to have your portal will look something like this, okay? As Dr. Rizwan was telling us, here on the right side of the screen, let me highlight. Spotlight. Okay. So here on the right side of the screen, if you see here, the video will appear on the left side of the panel on your portal, which will be personalized to each of the past participant who would register to this course. You'll get the So you'll get 12 weeks full access to this portal. And how to join this portal, instructions will be sent to you via email with all proper guidelines to follow. And session videos will be uploaded regularly on the portal. There will be pre-reading notes. So before you come into the session, you have to make sure that you go through those notes, and there will be history guide on your portal, case explanation. I'm going to come to the detail of case explanation. What is that? And there would be rapid review and exam recalls with useful links that we have collected so far keenly for you. Okay, and there will be examination of all systems checklist there, so you make sure that you're getting everything right while you're doing the examination. All right, so this is how your reading notes and history guide would appear on your portal. On the left-hand side here, your reading notes. For example, today we are going to discuss about transient ischemic attack. So, for example, if your session today, you will be shared a schedule, which I'm going to share with you shortly. You'll see on your portal the reading notes for transient ischemic attack and history guides. So you make sure that you read those on your portal, and then you attend the session. So your roster will somehow look like this. It will be a live roster. It will be shared with all the participants, and it will be live. So all the changes you will see there as it would happen. Right. So here are the many books that you require. You require all the books to pass OSCE, and the guidelines that are required are NICE guidelines, RCGP guidelines, and yeah, for infections, for malaria, for local disease, RCGP tells us to follow WHO guideline. So I have condensed all those guidelines for you. I have read all those books and extracted the very important keynotes for you from all those books. Okay, so you don't have to read those books again. However, you will be given access to these books as well. Okay, so how would you prepare OSCE with us? So first things first, please take MRCGP OSCE exam very seriously. Trust me, it's the foremost and the only advice I could give you, take home advice today. Please take it seriously. It's not an easy exam, okay? If you think that you are now, you can commit yourself to exam, please book a date. Otherwise, if you are not serious, you think that you are not able to commit to it, not able to give it sufficient time, please don't till you think that you are ready. Okay, before the session, go through the reading notes and history guide on your portal and attend every session. Okay, and you participate in role plays, and me and my team would give you your personalized feedback, right? And then you go and watch the session videos and practice with each other. You'll also be in groups, in WhatsApp groups, where you can connect with each other and make subgroups of 3s or 4s. And that's how you're going to practice on the gap days. On the gap days, you'll be given, there will also be exam scenario list on your portal. So on the gap days, make sure that you cover all those exam scenarios for that particular session, which was done on that. For example, if a CVS was covered, cardiovascular system was covered during a particular session, and there are gaps for 2 days till the next session, then during those 2 days, you're going to cover all the scenarios, okay, which have appeared in the past recalls during MRCGP OSCE. Right. And please make it a habit of practicing at least 6 to 10 cases. The more, the better. Trust me, from day one. No gaps, no Sundays, no holidays, no independent days, nothing. Just religiously every day till the date of exam for 12 weeks. Please practice 6 to 10 cases daily with each other. Right. So this is how your OSCE station looks like. Not exactly, it differs from region to region, but this was the closest image I could get on Google. So there would be 14 stations, active stations, and there would be 4 to 5 rest stations in between. Okay. And you see that there are instructions outside the station. Here are the instructions. So these instructions won't tell you too much about what's the case inside. Most of the time, it's very vague instruction, just telling you the details about the patient. That, okay, I'm going to get into the detail in further slides. Okay, so the same instruction will be outside your station and inside as well on the table. So once you get inside the station, the very same instruction will be on the table, so you don't have to remember the instruction which was written outside. So you will be getting 1 minute outside the station to read those instructions. And when you go inside, when the bell rings, you go inside, then you are going to have 10 minutes, active 10 minutes to manage that case, right? So when there are 2 minutes left, then there will be prompting, like someone would call loudly, 2 minutes left, 2 minutes left, so that you would know that if you are somewhere lagging behind, you quickly wrap up that case. And final whistle blows at minute 10. All right. And trust me on that, you're not expected to pass all the stations. This is as per RCGP curriculum, RCGP guidelines. Okay, so you'll be assessed. So the instructions, how would the instruction appear to you? It would appear something like Mr. X, age 40 years, presented with a problem, take history, do focused examination, and manage the patient. So there are 3 prompts there: take the history, focus examination, and manage the patient. Or there would be instruction like take relevant history and manage this patient, examination not required. So where there's clearly written outside this station and inside this station on your instruction where examination is not required, so it means that you don't have to do any examination, you won't gain any marks, however you lose your precious time, right? Or there could be take history and manage this patient. So in this situation, examination depends on the discretion of the candidate, whether the candidate thinks that is it necessary to do some examination or don't do it. It will depend on the candidate's decision, right? So what actually examiners are looking for? 2 things: if you are a safe doctor, and whether you are able to practice independently. Safety in terms of whether you can identify the risk a patient has posed to you, or were you able to manage the uncertainty or multimorbidity, and are you able to deal with the common clinical conditions, and do you know your limitation? Of course, we all know as GPs that there are certain limits, the guidelines, the referral guidelines. So how sound you are on those guidelines? How is 6 weeks referral? When is urgent referral? 2 weeks referral? When is 48 hours follow-up? Things like that. So you have to be they would be checking you and they would be testing you on those skills and independence in terms of that, whether you are able to function unsupervised, handle the cases and justify your decisions, take the responsibility of your management plan, and you behave very professionally, taking all ethical implications of that case into consideration. So these are the marking domains by RCGP. So this is kind of I have just copy pasted it here. So it's kind of very haphazard, right? And I'm going to organize it in the further few slides for you. So they will be testing you on your skills like consultation skills, whether you are repeating questions or not, how organized you are in progressing your case, whether you are able to pick up cues, whether you are able to rule in a serious disease or rule out a serious, you asked red flags or not, and your management plan, your rapport building. So we are going to discuss each one of those marking domains in detail. So while you're performing in that station, your examiner will be judging you that whether you are collecting the relevant information and whether you are making use of the existing information, right? Which whatever is written on your instructions, like the age of the patient, the gender of the patient. Sometimes they give you blood pressure, sometimes they give you fever, so that you know that there is something wrong, but this is infectious case, and whether you are exploring the red flags. And you will be also judged on whether you have explored the psychosocial information. Trust me, psychosocial information is very, very, very important. I'm going to discuss in detail with you. Okay. And then you'll also be assessed whether you are able to generate a working diagnosis after you are done with the history taking. And right, like in real cases, our patient presents to us with multiple complaints. So they will assess you whether you are able to prioritize the issue, which one is important and which one to take forward during this, at this point in time for this particular patient. So that is very important. And you are going to be assessed on that as well in particular station. So, and yes, you will be assessed if your treatment, the plan you have given to your patient is evidence-based, up to date, it's not outdated plan, and whether you have provided your patient with the appropriate investigations where they were appropriate, you have give prescriptions to your patient, and referral where appropriate. You don't have to miss any of those where appropriate, right? And yeah, some station, definitely there would be a station where they would be judging you that how do you handle the emergencies. It's very important. And yeah, so there are not all cases require lifestyle changes. So where they are relevant, you have to give those lifestyle advices, as we call it in GP language, non-pharmacological. So are you able to recognize those stations where they are deemed necessary? And are you able to manage the multi-morbidity, like a diabetic patient complains of pedal edema, puffiness around the eyes, non-compliant with his medication, is hypertensive as well. So he's presenting with multiple complaints. So are you able to manage that? Actually, this was actual scenario that I just spoke about. Right? Are you able to manage uncertainty? What if your patient, she comes with diagnosed, she has been diagnosed with breast cancer, and she asks you, doctor, how long will I able to live? So there's some uncertainty there. How will you handle that? So it's a way of handling that uncertainty, right? So yes, follow-up is very important, whether you're able to give a follow-up plan to your patient. And flexible thinking, trust me, is very important. You have to make changes right then and there according to the patient's ideas, concerns, and expectations. You have to be a flexible thinker. You don't have to be rigid. That's what we call patient-centered approach, and that is what is called flexible thinking. And you will also be assessed on your overall performance, whether you are acting in the best interest of the patient, and whether have you recognized the impact of the problem on patient, not just on the patient's personal life, his job, his work, his family, his mental health, okay, his relationships. So you have to explore on that, and how I'm going to explain to you shortly. And do you respect patient's autonomy? And yeah, cue handling. It is very important whether you are able to pick up the cues which your patient gives to you. And yes, you have to explain, and you have to manage the patient in a language which is understandable for your patient. It must be jargon free, non-medical, easier term. And by the way, I have designed a whole document which I have named jargon switch. Okay, so for abdomen, you can go through that document on your portal. And could you mute the participants, Dr. Adil? Right. So if abdomen, you have to say abdomen to your patient. So the switch word would be tummy. Okay, so there would be a document on your portal where you would be able to see the alternatives. Right. So after they assess you, they would pass the verdict as clear pass, pass, fail, or clear fail. So I hope you all pass. Okay. So my best wishes to you and good luck. Right. So to manage your case, you need two things: a structure, a consultation structure, and some consulting skills. So what is consultation structure? So as you can see that at the bottom of the screen, there's a timeline of 10 minutes and I've divided in half at minute 5. Okay. So before 5 minutes, there would be two parts, the patient's part and there would be a doctor's part. And after minute 5 or 6, there would be a clinical management going on, okay, which would be mutual between you and your patient. So this is the main structure you have to work on. So what is consultation basically? Uh, Consultation is simply, if I talk about very vague, jargon-free, understandable language, it is a process of converting a problem of your patient into a plan, right? So your patient comes to you and tells you, Doctor, I have this problem. And you tell your patient, I have some knowledge and skills and resources to help you. And in 10 minutes time, we have a plan, you and patient, you agree on a plan. Okay, so this simple terms, in very simple terms, it's as simple as that. I couldn't simplify it further. This is what whole 10-minute consultation is all about: the patient's part, the doctor's part, and then a plan together. Okay, right. So what the patient wants to tell you in the patient's part, it's the patient's perspective. Basically, the patient narrates you a story, okay, what's been happening and how is it impacting his or her life, and what does she think about it, how does it affected her life, her relationships, her work, or her finances, and XYZ. Okay, so that's the patient's part. Then what happens? Then comes your part. You have the clinical judgment, you have the medical knowledge, you have the resources, you just organize, you just gather information from the patient's part and the doctor's part. You gather the information from two people, patient and you as a doctor. Okay, and then you make a provisional diagnosis. Okay, in terms of medical terms and in terms what the patient needs. Okay. Okay, and then when you organize that information from the doctor's part and you organize it in your head, you make a management plan, management option for your patient. And your management plan should contain explanation, diagnosis explanation, investigations where appropriate, treatment, non-pharmacological, pharmacological, referral, and educational resources, and credible reassurance. For example, if your patient comes to me and says, oh, doctor, I have a headache. And after exploring his concerns, he says that I think I have brain cancer because my uncle was diagnosed as having brain cancer last month and he had headache as well. So how would you give credible assurance to your patient? So there's a way of doing that, right? All right. And how, okay, you have made a management plan with your patient and you have done all those, the explanation and pharmacological, non-pharmacological, and referrals where appropriate and credible assurance, but you have to make it successful. That is the last part and very important. Anyway, which everything is well, which ends well. So this is how it would end well. Okay, you signpost when you move on in your management plan. Okay, you don't surprise your patient. Okay, you say, okay, I get that you have a concern about headache. How about we discuss few things what I have found in your examination. So you always signpost your management plan, right? And link your explanation, whatever you are trying to explain to your patient, you always link it with what the patient has been thinking. Okay, since you are thinking, but I have done the examination, I have explored the red flags, so I don't think that is the case with you. Okay, so you always link it with patients' ideas and concerns. That is very important, and that's would score, and is one of the marking domains of RCGP, trust me. And you also, so once you are done with the management plan, you ask your patients, so is there any questions about the plan? Is there any questions in your head, or do you want me to want to ask me anything about the plan? Okay, so this is very important. And you reach a management plan, you know it's a success when you both agree and you are both happy with the plan. Okay, and it's a very good practice that you ask you, because I did in one of my stations and they marked me as excellent, because I told my patient that, okay, would you mind recapping that management plan for me, so that I would know that you've got everything right in your head. And I could see expression of joy on my examiner's face, or and on my simulated patient. Okay, so it is that important. And good ending, thank the patient and say goodbye. Okay, so this is also very, so this is very petty things, but it carries a lot of weightage. Right, so we have discussed there are steps of your consultation structure. Step one is identify